Hi, this is Patrick Horn, president of GAP. Thank you to our sponsor, AbbVie, for their support of this podcast.
Hello, and welcome to today's discussion. My name is Carol Antequera, and I am a physician assistant in the Division of Gastroenterology at the University of Miami. And joining me today is Jennifer Geremia, who is lead advanced endoscopy physician assistant at the Brigham and Women's Hospital in Boston, Massachusetts. Welcome, Jen.
Thank you, Carol.
It's great to have you here today. So today we're going to be discussing diagnosis and management of patients with exocrine pancreatic insufficiency, and we'll be discussing a little bit about testing, diagnosis, as well as some of our treatment options. So Jen, typically the kind of patients that you see in your clinic, do you find that patients, when they come in, they may be complaining of chronic diarrhea, weight loss? Do they mention foul stools or foul smelling stools with an oily appearance? And how would you work one of these patients up?
Great question, Carol. So all that you just mentioned is fairly common in terms of EPI patients and how they present. There is a spectrum. Patients may not have all of the symptoms that you just described. They may have some, or depending on the severity, they may not even necessarily graduate to having steatorrhea unless they've lost about 90% of their pancreatic function. And all of the types of symptoms you described are flags that are listed in our AGA guidelines as far as screening patients for potential EPI as a differential diagnosis, as far as best practices. So I agree. I think patients present, the key being postprandial symptoms, because diarrhea certainly has a spectrum in and of itself as far as causation. So frequently postprandial pain, postprandial diarrhea with or without steatorrhea, which is often foul smelling. If patients, can't describe steatorrhea, they'll often say fatty floating stools. Also definitively weight loss due to the malabsorption. And with that, due to the fact that they're at risk for reduction in fat-soluble absorption of micronutrients, they often have fatigue and weakness related to that malnutrition. So I do think all of those symptoms present in the spectrum of EPI, but not each individual patient may have all of them.
Absolutely, Jen. You're absolutely right. And I totally agree with you. I have seen quite a spectrum of these patients come in. And I think one of the things that's really helpful in guiding us to thinking about this in our differential diagnosis is some of the risk factors, right? So some patients that we see, being that both of us work at tertiary care centers, are patients with cystic fibrosis or patients that have had pancreatic cancer or a history of chronic pancreatitis or autoimmune pancreatitis. And so these patients are already at risk for developing EPI. And so certainly patients with these types of risk factors are going to be at the top of my differential for thinking about EPI.
Absolutely. I think those folks that you just mentioned are the more obvious ones. There's a clear explanation, and EPI would be on our radar because they've either had Whipple's for cancer, or perhaps the cancer in and of itself is resultant in EPI. They've had very significant, profound, necrotizing pancreatitis is not an uncommon thing I see on the advanced service. So again, those patients are fairly obvious. I think that in particular in the outpatient setting where we sometimes can forget about this diagnosis is that these patients may not be as acutely sick or as obvious in terms of primary pancreatic pathology that as a causation. And so they either get labeled with another cause of diarrhea, functional IBS, and perhaps they also have that. But EPI can exist in other conditions. And it's been documented in both type 1 and type 2 diabetes. So naturally, if you're having pancreatic failure and you're not actually performing your endocrine functions, that concurrently you may lose exocrine dysfunction as well. Also, if a patient has had some type of foregut surgery, such as gastric bypass, there's a dyssynergy that happens when the enzymes secrete versus when it actually mixes with their food. We can also see this fairly commonly with celiac, when we've made sure that the celiac is in good control and they're not being contaminated or exposed, yet they continue to have symptoms. So we do want to think about it, even if they don't have sort of those obvious pancreatic diseases that we so frequently see in the tertiary care setting.
Absolutely. Thank you for mentioning those, Jen. Definitely things to also keep in mind when seeing patients like this. And so I don't know about you, but my most frequent go-to test for these patients, and especially when I highly suspect EPI, is the stool pancreatic fecal elastase. This test is fairly easy. It's non-invasive. It comes back quickly, and it really helps me to get that positive diagnosis for EPI, so that I can then, start these patients on treatment. I know that, like both of us working in tertiary care centers, there may be other types of testing that may be a little bit more cumbersome or invasive. But what do you think about this?
No, I completely agree. I mean, it's readily available. It's relatively inexpensive and well covered. I think the limitation there is just understanding that, ironically, the looser the sample is can affect the outcome of the test. And also, if we're talking more about a patient that does not have those expected diagnostic criteria of chronic pancreatitis, et cetera. And the AGA guidelines reference this as well, that when it's an expected that the patient's going to have EPI in a pancreatic patient, you actually don't even need to do a fecal elastase. But if you're otherwise going to work it up, this is the most readily available. But if it is normal, especially thinking about a patient that may have had a surgical intervention, again, like a gastric bypass, or they have even something like gastroparesis where it's more dyssynergic, then that test may be normal. So if you do have a suspicion that EPI is still a cause of the patient's symptoms in a more mild to moderate, less obvious patient, then our best practice guidelines recommend doing the fecal elastase, but you also can empirically treat. I have access to those more invasive tests like secretin testing, but that's an endoscopic test, has to be done by advanced endoscopy, and really doesn't yield a tremendous more information to guide our treatment planning. And we do it very infrequently in our center. One call out I would say regarding fecal fat, which is also readily available, is that a spot fecal fat is not helpful here. If you really want to do a fecal fat, it does need to be a 72-hour test with a controlled amount of fat intake of 7 grams or more per day. So it's not worth burdening the patient with just the spot fecal fat. And again, what is that sort of adding in terms of the ability to treat?
Absolutely. I totally agree with you, Jen. And one of the other things that I also keep in mind, and I, explain to the patients, is that when they do the fecal elastase test, it does need to be done on at least a semi-solid or solid stool. And in some patients, if that, it truly is impossible, then it's perfectly acceptable to start those patients on pancreatic enzyme replacement and get the test, because interestingly enough, placing them on the enzymes will not affect the result of the study. And so that's definitely something that I have found has been really helpful in our practice.
No, I completely agree. It's kind of ironic you brought that up because exogenous PERT therapy doesn't change the test, as you just alluded to, but sometimes I do it to help remind the patient that may not be as compliant or may think that they're otherwise better and don't need to continue therapy, as a reminder that, hey, this is still going on and you need to continue with your therapy. So that's just my own clinical pearl to help with compliance.
Absolutely. Thanks, Jen. That's really helpful.
So, Carol, can you tell us, kind of starting off, when you're treating these patients apart from PERT therapy, what other recommendations you may have to help with this patient population? What other recommendations you give them?
Sure, absolutely. So, as part of my assessment in these patients, I also, want to check labs for any evidence of vitamin deficiencies and things like this, which can be seen in these patients due to malabsorption. And so, of course, assessing, vitamin deficiencies is part of the workup. Now, once we have, a confirmation of pancreatic exocrine insufficiency, then we move to starting the patient on medical therapy. And this basically includes enzyme replacement therapy. And so, really, a lot of what I do once we have the diagnosis is also talk to the patient and educate them about, enzyme replacement and what it entails. And typically, I start by letting them know how to take the medication. For example, we want to make sure that they're taking at least anywhere between 25 and 40,000 units of enzyme replacement with a meal for those patients with like a milder form of EPI. And for patients with a more severe, we definitely want to dose them a little bit higher. And so really what that means is that they're going to have at least 2 to 3 capsules of enzyme replacements with meals, and then they can have one with snacks. And then also really important to note that they really need to watch their diet. It's important to also explain to them that they should not be drinking any alcohol or smoking, as this also greatly affects their symptoms. So I don't know, do you also do kind of an educational visit with the patients as well?
Oh, absolutely. I think that's paramount for both compliance and long-term success for these patients. It's, I think, not a surprise that this is a cumbersome regimen for them, but really, educating them on what the underlying pathophysiology is, what are expected outcomes. Because what I find is when patients come in and say that it didn't help or they're not feeling better, my first question is, are they taking their medication properly and consistently? Sometimes they may opt to take it on a PRN basis, which is not how it is should be used. And so we always have to delve into that sort of compliance piece. And then also sort of reassessing periodically, is their dose appropriate? Is the units of the capsules that we're giving them optimized? Is the number of capsules that we're giving them optimized? Because that will ebb and flow as well. When we're seeing a particularly sick patient, maybe after a surgery or hospitalization, they're at a lower weight set point. So as they start to get healthier and recover, maybe their demand for enzyme is going to be higher. As they feel better, they'll start eating more. And so I try to keep this really simple for my patients. So exactly as you alluded to in terms of the number of capsules, but I also, kind of give them little pearls like, okay, if it's your average day, it's exactly what you described, 2 to 3 with meals, 1 with snacks. But if let's say it's a holiday, it's Thanksgiving, you're eating all day long, you may want to up the ante to like 4 with that particular meal. Or if you're going to a restaurant and eating, fattier foods, multi-course meals. So also understanding that there is going to be a bit of a range, both based on their weight and what their individual meal consumption is at any one time.
Absolutely, Jen. Yes, that's very helpful.
So are there any sort of things that you look at when you see your patients back and you've started them on therapy that may allude to underdosing or potentially even too high of a dose of the therapy that we're giving them? What are some of your follow-up questions and approaches when you see them back?
Sure, absolutely. So I look at 2 things. One, I look at clinical response, what the patient is telling me, how they're feeling, what their day-to-day looks like. And then I also have other objective measures that I can use, like labs, again, fecal elastase, and kind of gauge, see where they're at. Understand if they're still having diarrhea. Then perhaps we may be underdosing. If they're having vitamin deficiencies, then again, we need to maybe think of potentially increasing the dose. But if the patient explains that they're eating well, they're gaining weight, they're feeling well, they have good energy, they're able to go about their day, feeling well, then that really gives the indication that the patient is at the appropriate dose and the patient is responding well to therapy. Um, Other than that, we just basically do, periodic follow-ups. If the patient does come across an instance where they feel that their symptoms are worsening, of course, we do a follow-up, sooner, or they can always message us and let us know what's going on. Is this similar to what you practice?
Oh, absolutely. I mean, patients, again, assuming they're compliant, which seems to be one of the biggest hurdles, should know relatively quickly if this is helping them. And so, bringing them back, even within a month is a completely reasonable time frame. Of course, if they're feeling worse, then we need to further reassess sort of causation, dosing, etc. I agree with everything that you mentioned. I do in my own practice. I do also, have a predetermined set of labs, even though they may be okay on this day, revisiting that 6 months, 12 months, whatever the appropriate interval is, depending on whether or not they've had any deficiencies and making sure that they're, consistently taking their vitamins. One thing I do, regardless of age, and this again in reference to our AGA guidelines and best practices, is even if they're, not the status postmenopausal woman at risk for osteoporosis, the state of malabsorption puts them at risk for bone density loss. So you should consider doing a bone density scan in these patients. If you're not comfortable ordering it in GI, then making a note of that and recommending that the patient follow up with their PCP. So this is irregardless of gender, irregardless of age, is also another sort of health maintenance piece in the more long view of continued follow up of these EPI patients.
Absolutely. That's really helpful. Thank you.
I'm curious, Carol, do you screen your EPI patients at all for diabetes? Do you do A1Cs in your patients or recommend the PCP check an A1C? How do you tackle that?
Sure, absolutely. If I don't see anything within the last year, I certainly also check it myself. But as you mentioned, that diabetes type 1 and 2 are risk factors for pancreatic insufficiency. So a lot of times patients will already be diagnosed, but certainly if they haven't been diagnosed and they don't have a hemoglobin A1C on file, I certainly check for that as well.
Great. Any other pearls or recommendations that you make to your patients?
Well, I think one of the other things that, I do talk to them about are some of the psychosocial effects of this condition, right? It is something chronic for most patients. There's really not much of a cure, although we do have this enzyme replacement therapy, which will help them if adhered to appropriately. And so I really kind of go through the expectations that this is somewhat of a chronic condition, and that they should really be in the mindset that they're going to be taking these supplements, basically lifelong. And so I think that that also is really important to note, especially because, like we mentioned, if they're not adhering to therapy, they may fall into an instance where they're having symptoms again, and of course that can certainly impact their quality of life. And so we kind of try and set those expectations to try and prevent that.
Absolutely. I think, just kind of always level setting, appropriate follow up, revisiting, compliance, making sure they're up to date on all their appropriate testing. And, just like any other chronic GI condition, we have to see them back and set that precedent with the patient on the onset. So we also don't lose them in the long term. So it is certainly a partnership with the patient in the long run. Absolutely.
hmm I also find it very helpful that we have a dietitian on staff. And so I always refer those patients to our dietitian so that they can kind of go over their diet and make sure that they're also getting education about what foods they should avoid, what foods are safe, what they should be following, because I think that that's really helpful.
Oh no, I completely agree. That's the nutrition is also paramount in these malnourished patients. I also, just kind of thinking about long-term follow-up for these patients. Sometimes, these patients may not present initially with, again, a positive fecal elastase, and I think I just want to sort of impress upon that if if it's high in your clinical suspicion in your differential, that from a safety standpoint, these PERT therapies are very safe. And so if you're inclined to empirically treat them because of the limitations that we've already discussed, go ahead and do so, because generally speaking, when we look at the risk benefit scale, PERT therapy is very safe. There is the potential risk if patients were to take an extremely high dose that they could develop something called fibrosing colonopathy. And there are certain populations that we may need to be mindful of, such as those patients that either have a true pork allergy or may have a social or religious reason that they don't ingest pork. PERT therapy is porcine derived. So we do have to be frank with that with our patients and figure out a way to best approach that. But apart from some of these nuances, also patients with renal disease or gout, it's not a contraindication, but that would be one area that we may consider using a lower unit capsule versus the higher dose that I was referencing earlier. But apart from those little things, this is generally quite safe. So you can feel comfortable, despite the limitations of a fecal elastase, to go ahead and still treat them.
Thank you, Jen. That's very helpful to know.
Any other pearls or recommendations that you have for us today before we close out?
I think we've covered most of them. In general, I think we've really explained how we see these patients, that EPI should definitely be at the top of our differential in patients with symptomatic chronic diarrhea, or even that range of symptoms that we discussed. And then we went through diagnosis, which testing is most commonly used, how we use it, as well as dosing and education. So I think we've covered most of it.
Great. Well, thank you for your insights today, and thank you everyone for joining. You can reference today's conversation through the GAP ACE app or the website, as well as other resources and educational materials for GI and hepatology. Thank you.